helpful to look at what data is out there on it, and also look at a few case use examples. So I think the early application of LITT into glioblastoma really began with those non-surgically favorable tumors in deep and eloquent locations that you didn't want to go after with an open resection, be it butterfly lesions, thalamic lesions, other dominant hemisphere, very highly eloquent lesions. And certainly there's a wealth of data out there now from individual case series and grouped data from the Lantern study to show that it can be done and it can be done safely. But the question is, what's the efficacy, right? Because I think that in a lot of settings, probably not this group because you're here, so you must believe in this, but in a lot of settings, people would look at some of these difficult lesions and say, why bother trying to treat and causing a deficit? Let's just biopsy and then give them stoop. What's the evidence that if I'm going to ablate this, and especially if I'm going to ablate it maybe subtotally because I do want to just yellow line those eloquent areas, is there really a benefit to that, or should I just do biopsy? I think our best data in understanding the benefits of resection right now come from the RANO-RESECT group. And this study published in Neuro-Oncology in 2023 that was really meant to look at the benefits of supramaximal resection, which is now what we're talking about in the open surgical world, but actually gives us some important insight as to what happens when you biopsy versus subtotally resect, right? So LITT is effectively an ablative therapy. We're not cytoreducing, we're not relieving mass effect, but we are killing, destroying tumor. And so I think you can look at it equivalently to surgery in that sense. And what the RANO-RESECT group showed was that for biopsy alone, followed by standard radiation chemotherapy, the median overall survival was 10 months. But increased to 15 months with subtotal resection and up to 19 months with gross total resection, which I think you can view as the same as subtotal or complete area of ablation with LITT. So looking at direct LITT data, probably our best source is this study from the Lantern database published by John DeGroot and colleagues that looked at the outcomes in Lantern for survival. Now, this is a tough group to look at because this is retrospective data based on surgeons' selection of patients to treat with LITT. And so it's a very mixed group, and a lot of these patients are patients that were not really good candidates for open resection and either got LITT because of the location of the tumor or simply because they were so sick and so impaired that they didn't seem like good candidates for an open craniotomy. And so of course that group of patients is going to do worse. And when we look at the newly diagnosed data, overall that group doesn't do great. But if we look at the subset of those patients that were able to undergo ablation and then basically complete the induction of stoop, so the first 12 weeks of radiation and chemotherapy, that group's overall survival was about 15 months, which compares quite favorably to open resection, especially if you consider that most of those patients had poorly resectable or non-resectable tumors. And then, in addition, their complication rates were quite favorable with a very low neurologic morbidity. And so if you look at what I take as the take-home from this study, for patients who have a good enough KPS that will actually go on to receive radiation and chemotherapy after ablation, they can have a comparable survival outcome to resection, but a lot of times these are going to be patients who you would not otherwise take to resect. I think that compared to the RANO-RESECT data on biopsy alone, they're doing better if you do this than simply biopsy these lesions and give radiation and chemo. Recurrent patients will look at more primary data for that, but they did reasonably well also with a 9-month overall survival for treatment for recurrence. And if you look at the total complication and neurologic complication rate, it compares quite favorably to open resection, especially again when you consider the fact that these are the toughest tumors, right? These aren't right frontal superficial tumors. These are deep-seated, highly eloquent tumors. So what about at recurrence? what's the data for surgery at all, right? And you know, again, I trained at UCSF, indoctrinated by Mitch Berger, right? So we resect everything and totally, you know, 3, 4, 5 times. But the reality is in the community, you know, the number of people who are reoperating on recurrence varies quite dramatically, and people will ask what's really the benefit of reoperation for recurrence, which I think is a good question. So the RANO-RESECT group also put out a large study looking at re-resection, and basically what they showed was that for patients with first recurrence, median overall survival, if you resected, they're not even looking at extent of resection here, but if you resected versus no resection and just next round chemotherapy or reirradiation, there was a difference in median overall survival of 11 months versus 7 months, right? So clearly this data seems to suggest that there is some benefit to doing something surgical for these patients when possible. Now, what about LITT versus surgery? So, you know, Ian Lee's group at Henry Ford looked at retrospectively at a group of their patients that they felt had surgical equipoise. So they went through retrospectively, pulled out their patients and looked at those who had surgically resectable lesions at recurrence, and for whatever reason, again, there's biases here because this is retrospective, a handful of them went on to repeat open operation, and the other handful went on to LITT for those lesions, and then next best medical therapy. And what they showed is that there was really no difference in median overall survival, and that median turned out to be 14 months for both the LITT and open resection group, which compares quite favorably if you look at the RANO-RESECT data. So my takeaway from this is that LITT is probably equivalent to open resection, but if we look at the safety data with lower complication rates, certainly a lot more satisfaction on the patient side, and having not having to go through another big open craniotomy and go through the recovery from that. So I think case examples are helpful. They're anecdotal, but they still show you how we're using this in practice. So this is a 26-year-old male patient of mine who had an anaplastic PXA. And actually, when he first presented to us, I didn't know what this was. And he was 100% neurologically intact. This was an incidental finding after a seizure. And so, the decision is difficult. What option do you take on this? This is highly eloquent. If you're going to resect this openly, it has to be done awake, in my opinion. And we certainly do plenty of that, but I took a more minimally invasive approach at first because I didn't even know that this was necessarily going to be a glioma. And so what we did was put a tube retractor down to this and just centrally kind of core it out. So it was a subtotal resection. I was surprised with the pathology and then had to make a decision: do we go back and try to do more, or do we go on to radiation and chemotherapy? He opted for no further surgery, and so he underwent radiation and temozolomide, and a year later it's basically recurred looking the same as it did initially. So what do you do with this? Again, he's still 100% neurologically intact. The option to go back in and do an awake craniotomy is certainly there, but I thought, what about LITT for this, right? Because this is ideal location. And so, we did this 2 trajectory. Heat distribution was great, and we got an excellent ablation on this, and we don't have to go through the entire video, but basically got very, very good coverage. So this is, his recurrence. This is the immediate post-LITT scan. You can see the typical changes there. A few months later, 3 months later, you can already see massive regression there. And now this is his most recent scan a year after treatment, and he still has excellent local control. Who knows what's going to happen in the future, but he did not get this kind of result from subtotal resection, radiation, and chemotherapy. He's now had LITT alone, and it seems to be holding robustly, at least for the moment.
So he's on no other chemo?
He's on no other systemic therapy right now, yeah. So this is an example of a patient who's so functionally intact that you don't want to take the risk of causing a deficit. He's young, he's working, he's needs to work, has no other source of income or family help and social network, so if he can't work, he can't survive. The reason to do LITT in a case like this is to minimize that risk of deficit. The alternative is a patient like this. So this is an 80-year-old gentleman who presented to us in 2022 with left arm weakness and this glioblastoma basically in the hand knob. He was very, very functionally impaired from this, as you might expect. We did an awake craniotomy for this and resected it with minimal worsening of his deficit. He still didn't regain much hand function, but otherwise had good upper extremity function afterwards, and then went on to standard radiation and temozolomide and did quite well for 3 years. But recently represented with this recurrence, and he now is 83. He's had radiation, temozolomide. He's declining. He's barely ambulatory anymore because of balance issues. He's not using that arm well, so he can't use a walker. He's just not a good candidate for surgery because he's so frail, right? So here's a patient where we could resect this, certainly, but he just doesn't look like a good surgical candidate. So instead, we proceeded with a laser ablation for this and got nice treatment. This is only his 6-week follow-up scan, but we're seeing stability there. And we've actually combined this with another round of chemotherapy using lomustine, which I will talk about in a second, the reason for that. This paper from Dr. Barnett's group shows I like it because it shows the early practice details at Cleveland Clinic about how they implemented LITT for a number of different tumors. And you might think that the absolute use case for LITT is really in recurrent METs versus radiation necrosis after radiosurgery. But you see that the greatest area of growth in their early practice was actually in gliomas. And we found that to be true in our practice also. So once you start using this for gliomas, even though that's not the application that you might think of most readily, the outcomes are so good compared to surgical outcomes in glioma that you really want to keep using it, especially for those frail patients or patients with eloquent tumors where you're trying to preserve function. There are also additional benefits biologically to LITT in gliomas. And so the group at WashU has published on this extensively, and I think this was mentioned earlier today that there is radiographic evidence that LITT permeabilizes the blood-brain barrier. And on delayed contrast MR imaging, you can see increased permeability that lasts up to 4 weeks post-LITT. And so they actually asked the question, does this allow us to get chemotherapy that otherwise wouldn't get into the tumors in there if we do LITT? And so in the bottom there you see an animal study that Albert Kim did using doxorubicin, which doesn't cross the blood-brain barrier in humans or mice. So this is with orthotopic mouse gliomas treated with LITT or doxorubicin or the combination of LITT and doxorubicin. Doxorubicin alone in this group basically did nothing for the tumors. LITT had some effect because it is ablative, but the combination of the two had a substantial increase in survival. And they actually followed this up with a phase 2 human study, and unfortunately the conversion from Mac to PC here has shifted the imaging here, but what you would see if this was displaying correctly is that they found that patients treated with doxorubicin again for recurrent GBM after LITT actually saw a significant improvement in survival even compared to bevacizumab as a historical control. And so clearly there's something going on with the biology there. Also alluded to earlier today is this study from Cleveland Clinic in which they asked for newly diagnosed patients, can we treat with radiation and chemotherapy earlier without complications because we don't have a craniotomy wound to heal? And they showed the results of patients treated in under 7 days following LITT for newly diagnosed GBM with standard protocol with really no adverse events related to the wound or combined treatment. So it allows you to get back to treatment earlier, and that's true not only in gliomas, but very importantly in metastases, where you can continue patients through their systemic therapy without having to stop it when you're treating recurrent lesions. So I mentioned this issue of CCNU, right? So we had this thought that if we are permeabilizing the blood-brain barrier, can we give very early alkylating chemotherapy and get higher doses into the brain during that window than we would otherwise? And so, you know, for patients that we don't put on a drug clinical trial, our standard is to use CCNU as second-line therapy after reoperation for recurrence. We asked, could we take these patients who might be surgical candidates, but instead perform, or might be open surgical candidates, instead perform LITT and then give CCNU starting post-op day 1, and see if we can't get higher levels in there and get more of an effect. So we've actually been doing this for a while, kind of just as therapy, but we decided to formalize it into a trial. So we have a phase 1 study that's actually opening this coming week, in which we are taking patients with imaging progression of GBM, treating them with LITT, and then starting CCNU at under 7 days, and then following them for toxicity assessments for the combined therapy as well as survival outcomes, and comparing it to 2 historical control groups of patients treated without surgery and just CCNU for recurrence, and patients treated with open resection and CCNU at recurrence. But of course, there the therapy was started usually 3 to 4 weeks out from surgery. But just to show you some results that we've already had in the earlier patients that we kind of piloted this on. Here's a patient with a recurrent glioblastoma. This recurrence was diagnosed, but after discussion of tumor board and planning for LITT and so forth, some time had passed by the time we got to the procedure, and she had had pretty rapid growth from the first radiographic change to the time in which we treated her with LITT. We ablated this and got a very nice ablation on it, and then started her on CCNU day 1, and she's so far had her first 6-week interval imaging with no further progression in the lesion. Again, we're early, but if you look at how quickly it was progressing prior to treatment, we've at least slowed the progression of this. So considerations for limitations, right? And this has been brought up, but I really, really want to highlight it, especially for gliomas, is that we are not reducing volume. In fact, we're increasing volume. For viable tumor, whether it's glioma, MET, anything else, almost always we see an increase in the edema after LITT, and we're often starting with large lesions when we're talking about especially newly diagnosed GBM. And so you have to have a plan to deal with that edema, because I've seen patients also come to the verge of herniation within the first day after laser ablation, and thank God they were in the hospital and we could rush them to the OR. But you could imagine what would happen if we had sent them home within the first 24 hours. I like this image. So this is something that we did. We did volumetric assessments of tumors of the boundary of what we were going to ablate, and then superimpose the immediate post-ablation on there, and you can draw the pre-op volume over in the window there, the post-ablation. And you can see that the ablation line immediately exceeds that of the original tumor boundary there, drawn in orange. And if you actually do volumetric analysis on this, we found that lesions treated up to blue line to the lesion margin expand by 15 to 20% volumetrically immediately at the end of the ablation. That's the final scan in the scanner with the probe in, right? So, you start with a large lesion, 15 to 20% volume expansion is pretty significant, and that's before edema has even set in. And so, what do you do with that? And also remember that the larger the lesion you treat, not only is dealing with the mass effect a problem, but getting the full ablation becomes harder. And data that's been published before, and the Lantern data that you just saw that is in the works for publication, all shows that the extent of ablation is important. So this is a recent publication from the Miami group where they suggested that they could safely treat very large volume lesions and get similar outcomes to treating small volume lesions for newly diagnosed glioblastoma. And Mike Ivan is a good friend of mine, but I've told him he's crazy about this, because they advocate in this publication that they can do LITT alone without any kind of volume reduction for these very large, deep-seated, newly diagnosed GBMs. I do not feel that that's a safe approach, and I would bet most of the people with experience in here would agree with that. You've got to think about the volume reduction. But very early when I learned this lesson, I was looking through the literature and learning how to do this, and Andy Sloan published this back in 2016, the idea of doing a planned LITT ablation to a very large tumor and then coming in minimally invasively with a tubular retractor and resecting it. And this actually makes a lot of sense. It keeps it as a two-stage but minimally invasive procedure. And the laser ablation does devascularize these lesions and softens them. And so they suck out very easily. They're not as bloody, not as difficult. And if you've ablated up to the margin, then you're not as concerned about resecting right at the interface, right? And that's really where the danger zone is. So if you ablate to the margin, you get your 100% ablation. All you have to do is core out the lesion to reduce the mass effect, and you still get the same effect. And so we started playing around with this first with smaller lesions in patients that just weren't good candidates for big open surgeries. So this is definitely a resectable lesion open, but it's an 80-year-old frail man who presented with aphasia after a seizure. So we decided to ablate this. And then his aphasia worsened a little bit, no surprise, from the edema and so forth. So we took him back and put in a Vicor tube and just sucked it out. And when you do this, my goal is always to see a scan like this, where you see a little bit of the ablation volume still there at the margins, a little bit of enhancement, which tells you didn't go too far into the fiber tracts beyond the core of the lesion, but you get off the mass effect. And since doing that, we've started doing this more frequently for really large lesions where there's no other way to do it. So a large lesion like this, dominant perithalamic, open resection, this is very dicey. This is kind of what LITT, I think, is meant for in newly diagnosed GBM, but this patient already has a lot of mass effect. It's going to worsen. So we took her and did an ablation on this, and it was a two trajectory. Obviously, this is kind of bilobed, and got a very nice ablation on this, but you can see the increase in mass effect already. There's more shift there at the midline. And so took her back, put in a tube retractor, and tried to stay inside the lesion, right? The goal is not to get out all the enhancement, it's just to decompress the mass effect and get a nice result there. So, in summary, LITT, I think, is an excellent alternative for open resection for patients who are not a good candidate for craniotomy. I still do the vast, vast majority of GBM resections as classic open resections, a lot of awake mapping and so forth, because we are, the data does show that if we can get super maximal resections and do lobectomies, there is a survival benefit there. But in the right patients who are not good surgical candidates, there is still a benefit over just biopsy to doing these ablations. You have to, consider the mass effect and have a plan for addressing that. And I think a combination of LITT and minimally invasive craniotomy is sort of the ideal there. And then, also consider the biologic advantages of LITT. And I'm really hopeful that we're going to see, this combination of LITT plus chemotherapy and what was discussed earlier. The data's not out yet, but there are a number of studies of LITT plus immunotherapy really capitalizing on the biologic changes that happen in the tumor after the ablation, which may be more effective than simply those therapies alone or surgical intervention alone. So I thank you.
How are you accounting on the post-op imaging for pseudoprogression from the LITT versus true progression and breakthrough from the therapy that you're giving?
Yeah, so that's certainly a concern always, and so we are doing it based on judgment through tumor board assessment of every image. Because we're just starting this now, I don't know how it's going to play out in terms of how many biopsies we're going to end up doing. Certainly, that's going to be a major component of it. Is if there's a question, we will biopsy. Right now, we're going to be treating those patients though like we would treat recurrent GBM patients without other options, right? So even though it's a clinical trial, therapy will, we did this under a structure for pragmatic clinical trials that are funded by our cancer center, where basically we're using standard of care therapies in combination with each other. We would treat this as any patient on CCNU. So we don't automatically bail every time there's a little progression there. If the patient is doing clinically well, we'll continue therapy, and some of the recurrence boundaries are going to have to end up being retrospective when we have further scans in the future, see whether things stabilized out or continue to progress, and then sort of retrospectively assign whether it was true progression or pseudoprogression.
But are you including blood volume mapping or other things beyond just
so we always do.
contact
So our standard protocols, are advanced MR with ASL and cerebral blood flow, which we utilize to differentiate pseudoprogression from progression. But I don't know that we really know that well with LITT, what to expect to see there. And I'll show you some data in another talk related to METs that will show you that those kinds of imaging are not that effective when compared to biopsy. So we use them, but they're certainly not 100% sensitive. Yeah.
Can you speak to when, if ever, you would use LITT to treat GBM recurrence in a resection cavity? Like, is there a way to use it avoiding the cavity itself, and would it act as a heat sink, or?
Yeah, so we do that quite routinely. So if there's a focal recurrence, so a nice nodular recurrence right on the edge of a resection cavity, there are a number of technical considerations in there. The cavities work out nicely because they are a heat sink. If it's just a CSF-filled cavity, and you can use that to help push heat to where you want it, because you can get close to that cavity and then ablate at a very high power, and you know that you're going to stop at that cavity, and then it basically can turn a full fire probe almost into a side fire probe because you're going to ablate in one direction away from the heat sink. The challenges with recurrent lesions are how you're going to get to them, because often the most direct approach is probably the way you operated before, and you'd like to put the probe through the resection cavity, but you run a risk of losing CSF and then getting shift, and especially if the probe has to go through empty space and then penetrate into the lesion, a little bit of shift is going to really change the position of where you land. So we do our best to come from other angles and come all through normal tissue and not traverse the resection cavity. Yes?
Is there, I guess, with the LITT plus planned resection, is there sort of optimal timing you found to be able to evacuate the ablated tissue?
Yeah, so when we started doing this, I aimed to basically give it 48 hours from ablation to resection, with the thought that a little bit of time after the ablation will further devascularize and soften the tumor and make it easier to resect. What we found is that works nicely, but usually when we're doing this, patients are symptomatic from the increase in mass effect as we predicted, and that's why we pre-planned the resection. I've had a few patients who couldn't make it the 48 hours, and we've ended up pulling the trigger sooner. So for all of these patients, these are the only patients that I put in the ICU. So after standard LITT, where I don't think I'm going to need a resection, they go to the floor, or actually most of them never leave the PACU. They stay in the PACU for about 18 hours and then go home. But for these patients where you're really worried about mass effect, put them in the unit, put them on mannitol, do Q1 hour neurochecks, because I have seen a few decompensate even faster than we had planned to intervene surgically.
I guess I have more of a planning question. With the side fire probe, how does that change your planning? Because typically, if it's a regular, equally diffusing probe, you put it along the long rotational axis, of the lesion. So when you have a side fire probe, like, what are you thinking about in terms of plan? Do you put it in a particular area of the tumor to try to get it to go across in a specific way?
So I actually differ from Pete here. I exclusively don't use side fire. I used to when only the 3-3 probes, or when the 3-3 probes were the main workhorse. Since the NB3 came out, I agree. I love that probe. I use exclusively that probe. It's diffuse firing, but something about the heating characteristics, it heats better, it heats wider than the larger probes, and it tends to conform a little bit. So even though, you know, our tumors are not perfectly spherical most of the time, but heat does travel along the path based on tissue consistency and differences in tissue and edema surrounding the tumor. And you'd be surprised how nicely conformal the heat actually ends up spreading in a lot of these lesions, even though they're not perfectly spherical. If I have issues where one side is a little bit closer to eloquence than the other, and I do want to shift, what I'll often do is use multiple trajectories, but still with a full fire probe. So I'll put one probe trajectory away from the eloquence and use that to create a very large volume ablation where I might over-ablate on the safe side and then come short of the full tumor on the dangerous side, and then have another trajectory on that dangerous side where I do a very controlled ablation coming up right to the margin.